So that means you have to have a team. The needle goes somewhere else, the man will jump, right? But for interventional cardiology, you need a team. There's no way I alone can do it. You know why? I have to be monitoring the people. I have to be monitoring the ECG. I have to be monitoring the patient's alertness and symptoms. And then I have to try and cross that difficult artery. I'm not going to do that. Okay, so this is what it means to be an interventional. You have to be a team player. But right heart complications, pneumothorax. Some of you who have done central lines will cause pneumothorax already. If you haven't caused a pneumothorax, then you haven't done enough central lines. Pneumothorax, tracheal perforation, okay? Or you can go to the carotid artery with your needle. Intracardiac, so you might cause ventricular arrhythmias. If the catheter gets into the ventricle, you can cause ventricular tachycardia. You can perforate the atria. The wall is so thin and cause tamponade. All of these are complications that can happen. Major outcomes during left heart catheterization, mortality, unplanned CABG, stroke. So that means that if you start doing interventional cardiology, a CT surgeon has to be close by. You have to have a way of getting yourself out of trouble. All of these have to be well planned. An ambulance to ride the person to the ICU if you're in trouble. Myocardial infarction or ischemia, arrhythmias, requiring treatment, cardiac arrest, hemodynamic instability, major contrast reaction. Because anytime you inject someone with contrast, the person might react. So you have to always be ready. So, abrupt closure requires specific therapy. So, I told you, when you're in there with the wire, things can get messy. Okay? So the vessel can occlude. Distal embolization, coronary perforation, cardiac tamponade, stent thrombosis. I've seen all of these. Okay? And if you haven't seen them, then you haven't done enough. You have to be able to get them. Not that you're looking for them, but it will happen. So you need to know, anticipate, prevent, and then get out of this. So these complications are very low, but in Ghana, once we start doing them, they're going to go up a little bit, and then with time, will go down. Okay, so step-by-step approach to PCI. Appropriate indication, always appropriate indication. It's not because it's making money, it doesn't mean that you just cut everybody. Okay? You have to have communication, and you have to have communication with your referral physician to make sure that you both understand where you're going. Because if he stops some of the medicine prematurely, the person can have stent thrombosis. Appropriate patient, informed consent, team readiness, access and backup plans, anticoagulants, engage target vessel, cross the lesion, perform adequate angioplasty, perform PCI with appropriate size stent, and then perform post-stent deployment with balloon angioplasty. Completion angiography. Why completion angiography? So that you can see before and after. Did you lose some vessels? Did you cause a small bleed that you didn't notice? If you don't look and see a tiny bleed, because the wire can go all the way to the smallest vessel and perforate it. So you have to always look for that. And then you now conclude and observe the patient. So if you don't have teamwork, this is what happens. Okay? Somebody could have gotten out the car and take this animal away. Okay? And then you have a nice. Now, if that animal decomposes, you have a defect, right? So no teamwork. If you don't know how to have teamwork, you have to go back to school and know how to spell school. All right. Interventional cardiology, a must-have specialty for contemporary cardiac care, allows for advancement of cardiovascular care. Anytime you institute interventional cardiology, everybody's act goes up. The surgeons sit up because we can watch them. Okay, we can see what they're doing, and their clinical skills goes up. Without interventional cardiology, they become like vesica, and their death rate goes up. But once they have interventional cardiology and the cardiologists on board, their mortality rate goes down. And that's what we're looking for. It's not a competition, it's to make sure that the person survives, so that the primary care physician is happy. Percutaneous interventions, intracardiac interventions, pericardiocentesis, ICD, pacemaker implantation, all of these modalities. And we can now access almost all vascular beds using the radial artery. So some people are doing 100% of their intervention through the radial artery. Why is it important? Because the person can get up and walk quickly, the complications are less, the bleeding is down, but it's sometimes very tedious, in my view. I do them maybe 80% radial, 20% through the leg. So, for comprehensive cardiovascular care, we have to have collaboration, especially in Ghana. This is not a time to say, I know this, you don't know this. This is not a time to say, I have this, you don't have that. We have to work together to reduce this burden of cardiovascular diseases, especially peripheral arterial disease. People see how amputations are so common. We can prevent all of this. Set up chest pain centers, augment acute cardiovascular care, augment non-invasive labs, augment cardiovascular education, research, and publication. So we have to move forward if we need to stop these cardiovascular problems. To conclude, cancer, diabetes, and heart disease are no longer the disease of the world. Today, they hamper the people and the economies of the poorest populations, even more than infection diseases. This represents our millions in so much. So we stop right
because the streaming and okay, you can take this. See where the woman is standing. See where the woman is sitting.
You can put your hands together. We have to stop the stop wrong TV. I'm wondering what that means. Any questions, please? Any questions? The car, please. Please, as a car move. AW 10, 20, 12. I'll park behind somebody. 10, 20, 12. I think you walk with somebody. I hear you always be the bodyguard.
Alert, this not ejected properly.
So thank you so much, Dr. Any questions, please? I just want to find out how much are you doing in Ghana currently?
Pardon?
How much are you doing in Ghana currently?
I've done 5 so far, which is really high.
Yeah.
Last year 0, this year 5. So, and that's within the last 2 months. Because the cat lab in Colombo has started. And then there's a private person with a cat lab. So this. And now we're looking forward to Performance Cat Lab.
How's the support base like?
It's works in progress. Works in progress. So that's why I was emphasizing on the teamwork.
Because it gets very frustrating when you want to make the intervention.
Logistics, a big problem, but Medtronic has invaded the country. So they have a lot. There's a guy in Sydney. Sydney, and then there's also East Cantonment's pharmacy. They're going to stock a lot of stents and balloons. So anytime you need some, you can just get stents. The problem we're going to face with intervention, as far as acute intervention, leg or heart, is affordability. Who's going to pay?
Maybe people would like to know how much a stent costs.
A stent is about $800 in the drug unity. So there are 2 forms of stent. There's a bare metal stent, which is an alloy. And the problem with that is after maybe 2-3 years, there's new intimal formation. So there's going to be some new materials lying out and to narrow it in. So the ingenious people, including pathologists and everybody, came up with drug-diluting stents, okay, where they use cancer drugs, tacrolimus and other everolimus. And what it does is to prevent proliferation. So it moves, so you put they coat it with the medication. So when it's sitting in the artery, it is eluding that medication. That prevents new internal proliferation. So the risk stenosis is down. And I had a patient who had one for 15 years. So and it's clean. So they're small, but it's working. So those stents are very expensive. And the problem with those stents is once you put them, you have anticoagulation, antiplatelet therapy for a longer period. So we're trying to balance to see how long is enough. It's still a debatable problem. But at least, I think with our environment, if you have good flowers, not like concocted flowers, then you can give them for about 3 to 6 months. And if they need to stop for surgery, they may. But generally, 1 year is what we do if they have that route. If they have bare metal stent, means there's no medication around the stent, then 3 months of antiplatelet therapy, the new intimal formation is already there, so the stent doesn't cause any problem.
I want to find out, how often do you have bad complications in terms of years?
Like I said, if the system is well established, it's 1 in 1,000. 1 in 1,000. If the system is not well fixed, it will be maybe 100 in 1,000. The reason is the team members, especially with our nurses, the behavior. I'm not, if there is any nurse here, forgive me. But to be honest, if you compare team spirit in Ghana, elsewhere, you will win. You're going to win. And next, I was doing a case in Qatar at Kolebu. So I came in late. I was coming to have an intervention. Then I come in. So we started. My assumption is, now I know better. My assumption is that everything was supposedly said. So I said, okay, I'm going to give nitro. You have to speak out. And that's not what people here are used to. I'm speaking out, they're looking at me like I'm like I'm going to give nitro. Get IV fluids ready. They said, what do you want IV fluids for? You see? So I'm just giving you the reality of an infant industry. So I said, I want you to give bolus. So I gave the nitro. Pressure started coming down. Fortunately, his pressure was good. So he started coming down. I said, okay, increase the fluid. There's no IV line. Wow. So I said, okay. So I started, the manifold. You have the IV, you're connected to normal cells. So I just pumping the normal cells. Just draw pump. Okay, set the IV line. The nurse says, for the book, nurses do not set line. You've heard of that? Yes. I said, get out of the lab. I don't if there's been this, I'll kick her out. But I just took in a deep breath. And then did some Hail Mary. Then we had to stop. No radiation for a doctor to come in. So I told them, if you want me to come back here, all cath lab nurses must know how to set line. If you don't set line, then you're not part of the team. It doesn't make sense. So I am scrubbed. My assistant is scrubbed. There's no doctor around. It's 3 a.m. I'm doing intervention. I should stop and set the line. You see how teamwork is. So that's one example. The other one is the medications. They're not familiar. You're using hefty doses, 10,000 units of heparin, IV. The nurses are not used to that. Okay, so there's hesitation. So I think we need to do a lot of education and then get a team. Once you have a team, you have seasoned doctors like Dr. Wusu, help them, mentor them to get to a different level. Then you can work together. Yeah, so I'm telling you the complication will be high initially. We haven't, those cases we had, there was fortunately nothing happening. But you never can tell.
system where we buy a V8 instead of machines for the hospital.
Sorry, my voice is not good. I think that. But I'm just wondering, is it only the nurses that are having problems? Because from my own perspective, like you said, there's lack of teamwork. And apart from that, everybody thinks that it is the person who is at the top and he has a patient. So from everybody, from lab, because if you are doing intervention, you'll be doing your ACPs and other things.
Right.
How is it going? Because I'm just imagining how it's going to go.
Right. It's true. The problem is elsewhere there is accountability. Okay. So my work depends, or the pathologist or the lab's work depends on my work. So if I give them labs and they do it, they bill, and they will be held accountable. If I send them a lab and I time it, I expect it back in 15 minutes. They don't give me in 15 minutes, they'll be held accountable. Here, it's not like that. It's not like that. In my company, in my company. So if you're thinking of setting up a high-level care, you have to have everything controlled. You have to have everything under control. So you have to have your own laboratory. The ACT machine is easy to be gotten. It's an iStart kit. Or you have a system where everybody who is in your unit works together. You have to have. And then the NDC and MDB say, what? GGT, what is it? Eat and leave me or something like that. The jar or something. If you do the jar in a team work, and the next things you are chopping more than him or her, or the laboratory guy thinks you are chopping more than her, then it becomes a problem. Yes. Okay? So if you are, the doctors always are seen as taking more money than, and sometimes it's not true. It's not true, but that's the perception. So these are things that you have to blame. If you're working, this is how much we charge, this is where the money is going, this is what we do. Of course, it's a business. So you pay them well, you motivate them well, then you have them be accountable. But I think the best thing that can happen here is private settings. Private settings. In India, when they're just to see how their system is, and what the Indians, everybody has coronary. Everybody has coronary. So there's cath lab like churches in Ghana. The way we see churches everywhere, there's cath lab everywhere. And you can get cath lab, cardiac lab for $100. They probably a system, they recycle the catheters, so it's $100 cardiac lab.
They recycle the catheters?
Yes. Yes, they sterilize them, they wash them, they have HIV catheters, they have hepatitis catheters. So everybody who's coming for cardiac lab must get through HIV, Hep B, Hep C test. You have to have that. And the government has a number of doctors on call. Every region will have a doctor. Your phone is 24/7. You're on call. If the patient comes to Dr. Frimpong with heart attack, you send the image. Dr. Frimpong will send WhatsApp or whatever communication you use, the ECG, to the doctor on call. He approves, he gives you a number. Dr. Frimpong will go ahead and intervene and bill the government. They will pay. But elective cases will be based on asking the cases. So that's how they'll be able to control their interventions. So they have been able to do this. Here, the cost is going to be very high initially. Because one, not too many people are going to use it. So you can imagine get a cath lab for, say, 1 million. You have to pay for that cath lab. Then you have to have catheters. Then Medtronic is not going to give a discount, but you're only using many. You only get discount if you use, say, 1,000 a day. But you're going to use 1 a day, or 1 a week, or 1 a month. So they're not going to discount it. So the cost is going to be high. But as we do more, if Marcy gets 1 cath lab, Accra gets maybe 2, and it's going to be 2. That's 3. Then there are new hospitals coming up, about 3 new hospitals in Accra, which are all going to have cath labs. So I'm wondering who's going to do the interventions, because you have 12 cardiologists, okay? So you see how things are evolving. So we need young doctors to be trained. A lot of young doctors to be trained.
Thank you so much. I'm one invited to CEO of Spectra, and consultant international cardiologist to give us a presentation on private bank. Role of images in the management of sleep.
After that, come I don't know what to say. So, I think I'll make it short. I will look at how imaging plays a role and how on the diagnosis bed and the management bed, the follow-up beds, what can be done and what is being done now. So this we've already talked about. The CAT very has a lot of important morbidity and mortality, and diagnosis is very important for risk classification and also guides better management. And as of now, invasive angiography is still the gold standard in making the diagnosis. It detects luminous stenosis, but provides this information on the vessel wall and the plaques characteristics. So approach to diagnosis from imaging point, twofold. We have anatomical, there's functional significance to the type of stenosis. Classically, if you have stenosis of 50% or more, then we call it significant. Beneath that, usually the cardiologist will not do anything. In certain settings, you'll still have to be about 70% before they will intervene. And then imaging too can tell whether the territory or the patch you're trying to salvage will recover after revascularization. That's very important information that they need to know. Imaging too can assess global and regional ventricular function, and currently MRI is the best tool as gold standard that we do. And then we have plaque analysis, which we use your calcium scoring to look at and tell the depth, the strength of the calcium, the location, and then what it is causing. So we have non-invasive imaging. Interventional cardiologists will do the invasive one, we do non-invasive. And the first one we talked about is a calcium scoring. And that is a non-invasive tool that you use a CT scan to acquire. And usually you can start with a 16 slice, like now standard is actually 764 slice CT, which is non-invasively scanned in less than 5 seconds it will be scanned. And automatically most of these CTs will have software that will automatically compute and tell you exactly, can even tell you how old your heart is, whether you are, if you're 35, sometimes one time we did one, the person was 48 years, but the heart age was like 75. It was a young man who had like hypertension, does not eat well, the BP was 200 over, and his God doesn't care about himself. And it can actually tell you that it can even give you a risk, whether you can, the risk of having a heart attack in maybe this year. So it can actually do all that. Then you can do the CT angiography. Now increasingly, because CT technology has improved, you can use this 64, now we have 320 slice. That can tell exactly in terms of the stenosis. You don't need to do an invasive angiography to make a diagnosis. You can make diagnosis statistics of 99% as well as the stenosis and how bad the stenosis is, and how to decide on whether you want to go home. And then MRI, using MRI to do the same thing, but the CT angiography is better in terms of the spatial resolution. Then we can assess functional significance of stenosis. The patient you have let's say 70% stenosis. You still want to find out what it means. And there are other imaging modalities which we don't have
maybe in Africa, maybe in South Africa, but we have PET, which can also tell whether the part of the affected heart will survive or is worth reperfusion. You can also use stress echo, which also will tell whether the file will be viable or not. But what is now both than that, apart from what I mentioned already, because one PET, I'm not sure we're going to do that now in Ghana because you actually need to manufacture this molecule using between 2 hours. The Ghana countries not do it, so really we can't go there. But cardiac MRI has improved so much that it can actually tell exactly which part of the heart is dead and how dead it is. And also be able to tell whether you can actually see whether it will revive after trying to revascularize and treat it. So Spectra has been around since 1970 and used to drive you as we don't have one in the country. And how you use the Spectra to decide whether it's ischemic or if there's an infarct. So you need that decision to proceed. So if let's say you give your drug and the suspected area, there's a reduced tracer uptake on the stress acquisition, but it is reversible in the rest situation. Then it is ischemia, it means you can salvage this part of the heart. If there's an infarct, then it's a fixed effect on both the stress as well as the rest acquisitions. Now the other indications, and usually I'm sure most of this information can also be done by stress ECG. So you go through, you use the SPECT in certain conditions. That's when you have contraindications for performing stress ECG, inability to perform stress ECG, equivocal results, as well as abnormal rest ECG, which could not be interpreted as a result of the stress ECG being very difficult. It's generally sensitive, and that's about 86%, and not so specific, about 74%. And sometimes we have a false negative result, and that is when you have a train vessel disease, which means that because the spectrum is relative perfusion, all the vessels are affected, then you are not getting the relative analysis. So that can be a false negative. You can have false positive effect due to artifacts. Now this is a typical SPECT image, and here you have your rest and stress. You see that the effect persists, which tells you that it's an infarct. If the other way is that if let's say on the rest it is there and then the stress you are not able to see it means that it's ischemic. Then it means that you can really intervene with good results. With PETs, more expensive, not available much, but it also uses a similar principle of mismatch between flow and metabolism. And depending, similar to what I said already, we have a mismatch between flow as well as the use of the molecule, which is the fluorodeoxyglucose. Then you can taste an infarct. And it's also very sensitive, almost like that of SPECT. And then we have stress echo. I'm sure that cardiologists have already talked about. Low cost, widely available, sensitive, as well as specific. All right, and other ways to have to use stress echo, apart from just making a diagnosis, for risk classification, and more importantly, for preoperative risk assessment for patients that are going other forms of surgery, not just cardiac. So that make sure that the patient can survive, because surgery is known to be the best stress-inducing state, and that needs to be done. Because in assessment of valvular dysfunction. So how do you use, and when do you use MRI, cardiac MRI? You use it, one, for assessment of viability, assessment of cardiac function, which is still the gold standard now. You can do MRI, angiography, as well as wall motility. So for the viability assessment, we use similar stress-inducing. So you can use drugs, which is usually what is used. Sometimes you can use adenosine, or you can use one of the other drugs as well, to be able to induce a stressful situation and then scan. And usually in myocardial situation, the first pass, if you give the contrast, which is called gadolinium, and during the stress. Normally perfused myocardium enhances with contrast. Reversible ischemia is usually assessed as reversible low signal in the absence of a delayed enhancement. And an infant shows up as an enhancing area as opposed to normal myocardium. I'll show you an image to that effect. And usually, what we call the delayed enhancement is very important too, because it means that the cardiac area, the impacted area will enhance 10 to 20 minutes after the contrast is given. So this image here is a late contrast exam, and that shows enhancing of the endocardium. The enhancement is then persistent. It means that it's impacted, and you don't need to move any further in terms of trying to revascularize the vessel. As I said, MRI is the gold standard now for loop and left ventricular function analysis, and it's also superior to echo in that effect. Now, for a bit of comparative analysis, if you do a delayed cardiac MRI, it has a better negative predictor than the stress echo, and stress cardiac MRI compared with SPECT for multivessel disease is better in detection of some endocardial defects. So by and large, I think that if we need to invest in anything, we should be able to invest in the cardiac option rather than going to the SPECT and PET, which are actually more expensive and cumbersome to have around. And then we have also developed that you can have a good 4D. So in this one, you can use actually to assess how the motility of the heart is. So sometimes part of the heart wall will have dyskinesia. It can tell you whether it's even beating or still it's not beating at all. Usually infected areas will not beat well. I think I can play this video. So that shows how the heart will beat. This is how you're supposed to assess and see whether you're able to know how the heart is beating. This is a 4-vessel chamber one that we show next. And then you can have MR angiography, and that's your heart, and these are the left main as well as the left coronary arteries, and that is well depicted. Diagnostic accuracy quite high, 89% sensitivity, and most sensitivity of about 80%. And also let's talk about the Castle scoring, which is an important tool, and generally should be encouraged among all of us, whether you are 35 years or 40 years, as a man or woman, with any cardiovascular risk. And what it does is that the computer is able to quantify the amount of calcified plaques within the arteries. So it's an inexpensive examination, but has major information in. So generally for people with intermediate risk, that is age, men above 35, women above 40 years plus, hypertension, dyslipidemia, smoking, stressful lifestyle, sedentary lifestyle, overweight. And that's a typical calcium scoring, and that is the LED here. That's almost fully blocked by a calcified plaque. And when you see something like this, you might want to, with the appropriate lab, to do a CT angiography to actually assess and see how bad the stenosis is, so that you're able to intervene. Now it has prognostic role in the symptomatic patients. If a patient comes with a calcium of 0, the likelihood of having a heart attack is usually very much reduced. But it doesn't mean that it is nil. It can still be there, but highly reduced. If a patient also comes in with acute coronary syndrome and the ER, it has a low ECG changes, it has no negative cardiac exam, that's a calcium score and it's negative, there's a high, about 99% chance that there's nothing wrong with this patient. Patient can then go home. So it's a very important tool that we need to get into our practice. It's also known to be also in patients with renal disease that they tend to deposit more calcium. So the risk in patients with renal disease is high for cardiovascular incidents. And I think that there's not much literature done on this, and we encourage you to look into how these patients are affected in the development of cancer and coronary artery disease in general. In diabetics, no. Most patients, we've seen about 200 patients here already, and all the diabetics have calcification in their vessels, no matter how young that they are. So that is something that it's actually an independent prognostic indicator, And that's why at the diabetic patients, we should encourage them to screen as much as possible. Then we have a coronary CT, and that's for detection of stenosis, plaque analysis. Sensitivity, as I said, is about 99% for 64 slides, sorry, it was 66, and sensitivity about 64 to 89%. And you can use it in patients who come with acute chest pain and can help in classifying your plan going forward and when to send to the interventional cardiologist for urgent treatment. So that's a classic coronary angiogram. You can see that these white these are the calcified plaques. If you do calcium score, you see them, but of course, you can also tell. And you'll be able to do analysis to see, for example, this plaque here is almost filling the lumen of the vessel. And that is of significance. If you also maybe proximal, it has to be visited, it has significance. But generally, it's a very, very good tool that we need to talk about. I'll be ending shortly, but basically, I think that it's time that we as a country, as Thomas said, need to invest because by and large, heart attack is killing a lot of people on a daily basis. We used to think it was infections. I don't think that the population anymore. But people have it more frequently than we think. And currently, as we don't have any spec, no pets, but I'm sure that one day stress will go and deal with it. We have an MR cardiac. Actually, we have very good software with the system that have been bought in the country, both in Kolibu and Overnoche. The problem is that they don't work. And so we have them, but we can't even use. Particularly for Coronary, we're not even trained on how to use it. We're just one examination they did and then. But unfortunately, it doesn't work. Currently, the cases that we have a good CT scan that work for the cardiac, we have Aka House. They've been in operation for the last 5 years, or maybe 6 years, in doing some quite good work. And currently, to here at Spectra, we also do this thing. But generally, I think that we should invest our time and knowledge and education and building that capacity to be able to deal with this. Thank you very much.
We've had a good day. We couldn't stretch, but we have come to the end. Any questions, please? Any questions? It's a walk through the heart. I don't like the heart. I don't understand it. What I don't like is the ECG. Please, any questions? There are people like me, they are laughing. Anyway, thank you very much for that. I think it's been nicely organized, really nice place to sit in. I feel like the movie before the presentation. That's even better. But thank you very much, Mr. Chairman. We would like to hear something from you if nobody has a question.
Thank you. I think we've had a very nice evening. We started with the talk from Australia from Syrian. Then we had the pathologist also to pass it through exactly what causes the blockage. Then we had Dr. Musu to also tell us about how to evaluate. Then the interventional cardiologist also is giving us insight into what the state of the art, what is really happening. And actually, Dr. Rembo is my friend, but I didn't know that all these things were also being done here. I've had a very good and very insightful evening. A few words that I want to say, that we kept on saying that we should invest in, these type of modalities. But it's very unfortunate that if you go to our Ministry of Health, our emphasis is mostly on communicable disease. Non-communicable disease is actually an office. See, it's an office. And we have big programs for communicable disease, malaria program, TB program. Yes. And I mean it. Non-communicable disease is and all this. Yes, see, this is in contrast to what I saw in Mauritius, where their population is 1.2. The emphasis is rather on what? Non-communicable disease. And they need to listen to their health ministry. It is more non-communicable than what? Communicable. I know there are a lot of opinion leaders here, people who talk and people who are also into politics, with affiliations here. So when you meet these people, I think impress upon them. I don't want to do politics here, but what I want to say is that right now, when you do the rounds, it's so interesting because always you keep on saying that elsewhere. Yeah. So it's time for us to start talking to the right people so that they do the right thing for us. We thank all the speakers for very insightful and medical that was very good. If you were not around, I don't know, as chairman, I would have made the whole show would have been a bit boring. Thank you very much. Thank you for coming.
Thank you very much, Mr. Chairman. Please, if you have the forms, I'll be really glad to come. Because I don't know what to write, just write. Pardon me. Please, can we get pens? Could you please check for me? If you could borrow from a friend, we'll be very grateful. I have two. Just you write for 5 cities, please. Oh, sorry. Dr. Francis, could you please write through the form for me? You will fill it. God bless you. So we are just about looking. I'm sure there will be agitated. When we were younger, when we were in school, every presentation had some agitated, and it actually had a nickname called Juno, and we love to go, you know. And I'm sure that is the reason some came. I don't think you, but somebody else. So we want to just say a very brief thank you to everybody. I went to a function, and the pretty lady was called to give the vote of thanks. And I really loved the way she did it. I want to copy. So she came in on a high heel with very long flowing hair, speaks very good English, but I didn't know exactly what to say. So started on the note like, to Almighty God who made today possible, we want to say vote of thanks. So Dr. Paul, who hosted this program with NPC accreditation for only 100 Ghana cedis, is going to say a very big vote of thanks. To our chairman, Professor Egan, vote of thanks. To Dr. Isaac Owusu, vote of thanks. To Dr. Kaba, from moving all the way from Accra, I don't know whether on a flight or VIP or in your own car, vote of thanks. And to Dr. AJ for standing in for the other AJ who didn't come, also vote of thanks. And to all of you, vote of thanks. No one's please of mine. But anyway, I don't want to read this one because it's not that way. Because it's not that way. In fact, we just say thank you to all of you for coming. God bless you. We'll see you another time in Spectra to get conditional working better. And you just do so in an application. So when it's taken away, it's really much better. Thank you all so very much for your smiling faces. Nobody slept. Fantastic presentations. If you see there, problem. Let's go through this door. We're going to have something to drink and something to eat. We are nice doctors. This is going to go. This is a nice presentation. Eat small so that your coronary arteries will be patent for a So we want to say a very good thank you to all. Shall I will just be sure here to Father, we bless you for tonight. Bless us in Jesus' name. Amen. Shall we say hello to somebody as we walk out? Meet somebody you don't know. Could you please pass your sheets forward? Could you please just pass it forward? Thank you so much. Thank you very much.
piano, we're starting.